All right. Hello, everyone, and welcome. Welcome to our second of three webinars focused on 1557. Thank you all very much for being here today. My name is Matt Fiddler. I'm the Vice President of Client Experience for AMN Healthcare Language Services. We received excellent feedback on the first session that we did, and we heard three things loud and clear that we're excited to tackle for you today. The first is that you wanted to understand how the election results would impact 1557. Second, you wanted a clearer understanding of the remaining elements and definitions and timelines. And third, you wanted more operational examples. How does this apply to our daily lives? So very, very excited to work through that today. If we can go to the next slide, please. I'm happy today to be joined by, there we go, by Drew Stevens and Carla Fogaren again, these two partners in crime that are so insightful for us here today. Guys, thank you for being us, and thank you also to AMN's ASL and CDI interpreters who are participating in our session today. If we can go to the next one, just a reminder, please, that these presentations are for general informational purposes only. Nothing contained in this presentation or said during our session today constitutes legal advice. Okay, let's get into the agenda for today, please. We've got an exciting 2 hours planned for you today. As you peruse the agenda, let me remind you, please, of three housekeeping items before we dig into Drew and the content. First is that the session will be recorded. The session itself and all of the resources that we discuss and walk through at the end will be sent to the email you've registered with once the session is complete over the next day or so. We will have two Q&A sessions today. So as a reminder, please do put your questions into the Q&A tab, which you can see on the top. I will curate those for our honored guests as we progress through the session today. But we have added a second session. And the final thing before I pass off to Drew is a reminder that the third and final 1557 webinar is scheduled for January 15th at 11 a.m. Central Time. So please do mark your calendars now for our third and final topic, or our third and final session, rather, on this 1557 topic. Okay, Drew, if you would take us away, please, into today's agenda and the content you wish to cover, I would certainly appreciate that. Drew, please.
Thank you, Matt, and thanks for everyone for being here and for AMN for having us back in the second session. If we go to the next slide, we'll take a look at the various deadlines. At the top, you'll see we've already covered a couple of the deadlines that have now passed regarding posting notices of non-discrimination, appointing a Section 1557 coordinator. We covered those in our first session, in addition to general requirements, general overview, and some of the details around those two topics. If you don't feel like you're on top of those topics, feel free to go back to the first webinar, reach out to either me and Carla so we can help you with those. But today we're going to cover what is in green here. First, we'll start with just a quick note about this deadline on January 1st for benefits and coverage, health insurance coverage. It's a little outside the scope of what our main topics are, but it's worth hitting quickly at the beginning. Then we are going to cover a couple of different topics today. So it's going to be really exciting to hit each of these, starting with the regulation that goes into effect in May around ensuring non-discrimination in the use of what HHS calls patient care decision support tools, which can often be, shortened to healthcare AI, right? That's the main thing that they are targeting there, but it's broader than just AI. So we'll spend a lot of time on that. We'll also cover non-discrimination in telehealth after that, and Carla will finish the session talking about the notices of availability of language assistance services, and we will also spend some time walking through the requirements around written language access procedures and effective communication procedures. And so with that, we can go to the next slide. So as Matt mentioned, a question on everyone's mind, of course, is with the incoming change in administration, what is going to happen with all of this? And on the next slide, I have a few talking points to cover with you and share with you some of my thoughts. We've all seen this scenario before, several years ago when Donald Trump was elected the first time. years into his first administration, the administration did, in fact, go through notice and comment rulemaking to change the original Obama administration's regulation. And a couple of things to think through what we might see this time around. First, many of you will recall that the Trump administration regulation left much of the Obama era regulation in place around language access and effective communication, did not wholesale throw out those provisions, which itself is significant. Uh, so I think it's fair to expect that this second go around, the next regulation could look very much like the first, unless they decide to go farther this time and paring it back, which is possible. I think it's fair to think that it will look a lot like the first iteration of the Trump administration's regulation, which, just in short, really pared back a lot of what they considered the administrative burdens around notices, grievance procedures, and things like that, but kept in place those core language access and effective communication provisions. Now, all that said, the notice and comment rulemaking process will take time, just as it did the first go round. This regulation, like the first time this happened, can't be undone through the Congressional Review Act process, where Congress can just vote to axe a regulation by a majority vote. So the administration will have to go through notice and comment rulemaking again. So for a while, perhaps a year or more, the Biden administration's deadlines will remain in effect. So what we are going to talk about today will remain in effect and have the force of law. And so it's something that every health system, every hospital, every provider should continue to do to comply with the law and the regulation. And even if, everyone will remember the first time that the Trump administration came in, there was talk about replacing the Affordable Care Act. And just to emphasize, even if something like that were to happen this time around, much of this law that we talk about today exists independent of the Affordable Care Act. So independent of the regulation and independent of the Affordable Care Act itself. It really originates in Title VI of the Civil Rights Act, Section 504 of the Rehabilitation Act, and the Americans with Disabilities Act when we're talking about language access and effective communication. Because many of you will know the Affordable Care Act actually in 1557 just references these pre-existing statutes. So that is where this law really comes from. So I hope that's helpful to everyone as we frame the discussion moving forward, because even if most, or perhaps all of what we focus on today comes out of the regulation moving forward, it's still not going to happen for some amount of time. These are still best practices to comply with the law, provide the best care, and so it's worth still dedicating time and resources to studying these issues and implementing them moving forward. So if anyone has any questions about that, please feel free to reach out to me afterwards. Diving into the content, we'll spend one slide on this January 1 deadline that's coming up for health plan coverage benefit design. So this is something of a delayed deadline for healthcare coverage benefits to come into compliance with the regulation if they were newly covered by the regulation. So that may be outside the scope of any of our responsibilities on this webinar as it relates to benefit design, coverage design, benefits. But the important thing is that we can use this to emphasize this language from the regulation, that any of those of you on this call, this webinar, that have responsibilities related to coverage or benefits should bear in mind that everything that we've talked about, everything that we're going to talk about today is still required for compliance, because these health insurance providers, carriers are covered entities under the regulation and should be complying with everything that we've talked about and what we'll be talking about today. Okay, with that, we can move to the next slide, please. And we'll start with non-discrimination in the use of patient care decision support tools and AI. And what I have here is, as a starting place, what you're looking at is the text of the regulation itself. It's just 3 paragraphs long, if you believe it, that first begins with a general prohibition that a covered entity, hospital, health system, health insurance carrier may not discriminate in the use of patient care decision support tools on these protected bases. And we'll look at the definition of that patient care decision support tool shortly. And really, this regulation is subsection B and subsection C here, which imposes an ongoing duty on covered entities to make reasonable efforts to identify the uses of these tools that use what is referred to as input variables or factors that measure these protected classes. So hospitals, health systems, as of May next year, will need to have operationalized this ongoing duty to make reasonable efforts to identify those tools that do this. And we'll take a look at what that means in more detail shortly. Subsection C is the second part of this new standard, that for all of those tools that a system has identified, a covered entity must make reasonable steps to mitigate the risk of discrimination that results from the use of those tools. So this is something of a deceptively simple but very watershed moment when it comes to the regulation and non-discrimination in healthcare. Many of you will remember that it was quite a while ago that the Biden administration proposed the initial regulation under 1557, all the way back in early 2022. And initially, the proposed regulation used the term clinical algorithm. And there was just a standard prohibition on discrimination in the use of clinical algorithms. And then later that year, the Chat GPT revolution, is announced, comes out, everyone starts using it, exploring it. And it's as if, it was the invention of the internet or something else as significant as that. And there was a very long delay in finalizing this regulation. I think a lot of it had to do with this exact issue, is what policy was the Biden administration going to use in response. And so in response, they landed on this ongoing duty to take reasonable efforts to identify the tools that use these variables and to mitigate the risk of discrimination in the use of those tools. So it can't really be overstated how significant it is that this is going into effect in May of next year. Next slide, please. So let's start with what is defined to be a patient care decision support tool. And this is the definition that comes from the regulation. It is any automated or non-automated tool, mechanism, method, technology, or a combination that is used by a covered entity to support clinical decision making. So it covers AI, automated or non-automated technology. It covers flow charts, even written flow charts, something that is just a simple tool, a simple method that aids clinical decision making. So while we'll basically focus on healthcare AI, it's important to know that it's broader than that, and attention should be given to any tool, method, any technology that's used to support clinical decision making. But HHS was very clear that now, notwithstanding the change in administration that's coming, where we're likely to see a change in these standards from a public policy perspective, it's important to note that HHS had asked for comments on whether to expand this reference to patient care decision support tools to non-clinical decision-making tools. And the examples they gave were billing, scheduling, and resource allocation. So if that were ever to happen, it would essentially double or triple the burden, the obligation on hospital and health systems and compliance professionals to engage in this effort. So you'd have a whole arm of activity focused on clinical decision-making tools, and then also all of these more administrative tools, which do impact patient care and experience, of course. So that's just something to recognize, that while as written, these standards apply to patient care decision support tools that are clinical decision-making tools, there is this chance that it expands sometime in the future. So on this slide at the bottom, up front, HHS in the preamble to this regulation, it's really worth reading in whole. I recommend that everyone go and read the section on this standard in the preamble to the final regulation, where HHS expands on all of these principles. What does identifying risks, mitigating risks mean? Up front, HHS says the first thing that it means is that a hospital and health system has an obligation on the front end to conduct due diligence when acquiring and using these AI tools. So across the country right now, hospitals and health systems are doing exactly this. They're doing this due diligence across multiple factors, right? Cost, effectiveness, safety, quality. They should also be, and they are employing professionals to do this, examining doing this due diligence as it relates to non-discrimination. So I would be very eager to hear from any of you who are involved in these AI governance structures within your hospital and health systems, because in my view, the Section 1557 coordinator and other compliance and legal professionals who are responsible for non-discrimination issues should have a seat in those AI governance groups and on those boards, to be able to collaborate with the chief health AI officer and everyone else in evaluating these tools. So what does it mean to do this due diligence? HHS says it should consist of at least these 5 bullet points here. Maybe there are others. First is, at a minimum, a hospital or health system should be reviewing the required health IT disclosures from the certified health IT developers. So this is where there's a structure, a layered structure of all in the ways the federal government is trying to require disclosure of how AI tools can exacerbate health disparities or the risks of discrimination. And so the FDA and others are requiring disclosures of the risks. And there's a push in the industry to require something like a nutrition label, a fact sheet of what a tool is designed to do, how it was trained, what it's supposed to do, what the risks of how it might deviate from that. So you got to read these disclosures up front. Then, of course, review resources published by HHS, of which I don't think there are any right now for us to discuss, but at some point in the future, it's likely there will be guidance on all of this coming from HHS when it comes to healthcare AI. Monitoring academic literature, which there's already a whole cottage industry of analyzing health AI, reviewing media reports, of course, to kind of keep your ear to the ground on where risks might arise with different tools, and be involved in professional associations that are focused on this issue and the appropriate uses of health AI. So that's the upfront due diligence standard when acquiring an AI tool. And on the next slide, please, we'll look at what it means to identify the risks. Go to the next slide, please. Thank you. So what does it mean? The regulation requires you to take a hospital or health system to take reasonable efforts to identify risks. So what are you identifying? It's easy to skip over this because you're supposed to be identifying risks of tools that measure the variables associated with things like race, national origin, sex, disability. But what you hear at these conferences, when you hear from the developers, from the technicians, from the analysts, the designers, is that these tools, of course, are dynamic. The technology is dynamic. So even if a tool is not designed to measure or use those factors, it may for itself start doing that. It may for itself start to see the correlations and start to use those when it's making recommendations, when it is when it is giving providers options, when it's identifying risks. So it is almost as if inevitably a healthcare AI tool has the risk of turning into one that measures, that uses these variables, these protected classes like race, national origin, disability. So it's easy to skip over this. What are you supposed to identify? Because virtually any healthcare AI tool could be one that uses those variables. So how do you take reasonable efforts to identify the risks of discrimination? HHS says that first, you need to think about your system size and resources. If you're a large system with a lot of resources and a lot of professionals, then your efforts will look greater, especially if you're employing more tools in different situations across different aspects of care. So your efforts can be on a sliding scale based on your size and resources. And number 4 here on this slide is what we just talked about. Reasonable efforts to identify risks includes the due diligence process up front. So HHS is recommending that hospitals and health systems have a methodology or a process in place, some sort of procedure to evaluate the tools that it adopts. It shouldn't be ad hoc. It shouldn't be improvised. It should be a methodology, a process that is rigorous and adequate. Then, as I mentioned, there's a push within the industry to have disclosures and fact sheets and labels associated with each tool to disclose the manner and under the conditions that it is intended to be used, almost like a prescription drug. Where you have the on-label uses and the off-label uses and things like that. So a hospital or health system should at least be aware of any such disclosures, review them. You would think use them in accordance with the way they were designed or intended and approved, or at least if you're going to deviate from that, do so with complete knowledge and understanding of the risk. So if a health system is going to customize a tool, which again, if you go to these conferences, participate in these conversations, the developers will tell you there is no off-the-shelf tool to deploy across health systems. It has to be adapted, customized to be effective for your population, for your patients, for your providers. So there is going to always be a customization. There's always going to be modifications, and that entire process is part of making sure you're undertaking reasonable efforts to do so in a way that minimize risks of discrimination. And the third item to take reasonable steps to identify the risks is a little like what we've already discussed, is review the product information from the certified developer regarding the potential for discrimination. So you can't ignore these disclosures and feign surprise when you're seeing disparities in the use of your AI. Okay, next slide, please. So that was what is reasonable efforts to identify the risk. So for all of those risks that are identified, there is a second step required. Now that you've identified risks, you've got to take steps to mitigate those risks. And taking a step back, from a regulatory perspective, it's important to note that this is not a strict liability standard. Even if the Trump administration adopts this is the policy that we like and we're going to enforce. It's not some sort of strict liability standard. Under the regulation, when it comes to federal funding or enforcement actions from the federal government, it's a due diligence standard. It's a reasonable effort standard to identify and mitigate risks. So it's not as though identifying risks and mitigating them, you're admitting to liability in the eyes of the federal government. It's a due diligence, ongoing, reasonable effort standard. So what does that require? According to HHS, to mitigate the risks, to take steps to mitigate the risk of discrimination, the first thing, it makes sense, is there needs to be a policy and procedure for the use of these AI tools in clinical decision making and what many of you are involved in that we've already touched on is HHS recommends these new AI governance groups, AI governance committees within hospitals and health systems. And this is an entire new domain. These are a hot topic. And so that governance body should be putting out these written policies and procedures governing the use of AI within a system, and non-discrimination should be one of the focuses of that effort. Then how can you mitigate risks if you're not monitoring, ongoing monitoring of those impacts? So this is where I think from an operational perspective, the real challenges will emerge. So ongoing monitoring of potential impacts. So that suggests that there should be data coming in, being reviewed and observed, and monitoring where there are deviations that can be understood, can be identified along these lines of these protected classes. And then even if you monitor and see it happening, how do you develop ways to address them? It's easy to say, develop ways to address these issues. But what does that mean? And that's where the collaboration required to address AI drifting, making disparate recommendations based on suspect data, or even a clinician that doesn't understand the tool or is misusing it. How do you address those items? And so the collaboration required, it seems to me, will require AI professionals, the chief health AI officer and his or her team, legal and compliance, patient safety, because all of this implicates quality and safety at the end of the day. That if recommendations are coming from a tool that are discriminatory in nature, that is a safety issue. That is a quality issue. So, and of course, compliance professionals, including Section 1557 officers and coordinators, would need to be involved. So that's going to be a big area of focus for the industry moving forward, is equipping hospitals and health systems with the talent, information, resources, and skills and tools to proactively monitor and address these issues. So the third item dovetails nicely with that. Obviously, you have to train people. You got to train hospitals and health systems on what tools are being used, how they're supposed to be used, the risks that we're aware of, how to identify risks that we're not aware of, and how do you surface issues? How do you surface complaints to the right people? And then how do you try to fix them? That is a huge undertaking. And I think it may make sense here to pause, and I would love to hear Carla's thoughts on, from an operational compliance perspective, on everything that we just discussed, including this training and figuring out how to, as a team, to address some of these issues.
So I actually think AI is going to make a very big difference in so many areas in a positive way. But we need to put some guardrails on it. What really is overwhelming is, for instance, currently O2 SAT machines are biased, right? They've had evidence-based studies that came out after COVID or during COVID that people who are Black and brown were having their O2 SAT overestimated. So let's say that it truly was 85%, and I happen to be a brown person, it would probably come in at 90%. So I was actually sicker or less oxygen deprived than what it showed. So the interventions may have been anybody with an O2 SAT of under 90 would receive this kind of intervention treatment, and people who are Black and brown did not necessarily meet that because the O2 SAT machines with their AI were biased on it. So O2 SAT machines have been around forever. As a nurse, I've used them for over 30 years. So think about the implications it's going to have on hospitals and clinics to have to constantly be aware of what the changes are, what the warning signs are on the AI technology. This is good for people from age 30 to 50, but we find that there are some variations between females age 50 to 55. I mean, it's hard enough to just train staff or educate staff on the utilization of a piece of equipment or technology or interventions. Never mind all of these caveats, right, that are going to come out now, and it's going to be constantly flowing because, as you said, it learns from itself, right? So it it's going to be a real challenging, in my opinion, thing to do. And I just heard recently that AI developers are now also perhaps going to be held accountable for, like, if something goes wrong, Drew, like terribly wrong, that it won't just be the hospital, the provider, but it will also reflect back to the AI developer. Is that true, or is that just a myth that we're hearing?
I think it remains to be seen. I think that from a legal perspective, you can imagine like a product liability type claim against a technology that it was defective. But um, it it seems to me, when you purchase a tool and you take ownership of it and you start using it, the onus is going to fall most heavily on the hospital and health system. Now, from a regulatory perspective, that could be a little different. That the federal regulators see it differently. They have the way, the means, the capability to um, bring an enforcement action or investigate the developer differently than a patient might. But the FDA commissioner, for example, the current FDA commissioner, has done a lot in recent days to emphasize his view that all of these tools, when they get deployed in a system, it will be up to the hospital or health system to validate, to continue to validate and take these steps. And he's trying to sound the alarm that he doesn't think that hospitals and health systems are really up to that task right now. And so the job is to train, equip. The federal government's going to have to take a role in that process of enabling hospitals and health systems to do that. So, Carla, thank you. That was very helpful. I think we've got just a few more slides that fall under this category. If we go to the next slide, please. So now I just want to loop back into something that we've already talked about. It's not new. It's not a new deadline. It's new in the Biden administration regulation, and that's this requirement for a machine translation of text. Here's the definition of a machine translation of text: automated translation that is text-based and provides instant translations between languages. So, and this is without human involvement. So, the Biden administration, as a part of this AI technology revolution that's been unfolding, put into place this requirement that, next slide, please, for machine translation in certain contexts must be reviewed by a qualified human translator. And here's the three places in which a machine translation must be reviewed by a qualified human translator. And for as far as I can tell, these cover a whole lot of stuff that a hospital or a health system does. When text is critical to the rights, benefits, or meaningful access to healthcare, where accuracy is essential, or where the documents contain complex or technical or even non-literal, figurative language, the machine translation of that text must be reviewed by a qualified human translator. And so the AI revolution that we're all watching unfold, it seems to me, is going to bring this in even greater focus, because before then, I think I've heard it referred to as kind of the Google Translate rule, that all the reliance out there on Google Translate or other technologies to translate text for individuals who may have limited English proficiency, without double checking it, without having a qualified human translator who understands medical terminology, understands nuance and all of that. The federal government identified that as a serious risk and a serious compliance problem. Trying to, in good faith, perhaps use technology to help someone, but doing so without taking appropriate precautions. So, Carla, would you have any examples that jump to mind of where people on this call should focus should be thinking about when it comes to machine translation?
My famous line is, it depends, dot, 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 right? But it honestly is so complex. So informed consents for sure, right? Discharge instructions, because you want to make sure that the patient goes home safe and can stay home and not have to be readmitted into the hospital for something that could have been avoided. The cost is tremendous, both for the person, the patient, and for the hospital system. Any intake forms, like if I want to find out for a pain clinic, what your past history is, I'd better make sure that the intake forms are asking the right questions, because your answers are going to be something that I may not be looking for or may be distorted. I will tell you that the latest one I've seen, because AI likes to augment, sometimes make things up from nothing. It doesn't even make sense in some cases. But the latest one I've seen was a colonoscopy prep. The colonoscopy prep was done by AI, and it actually focused on where you're not supposed to eat and you're supposed to be taking the prep. It actually said that good nutrition is very important to be healthy, and that you should have like a full meal. I mean, it was just like crazy. So imagine the patient following that, showing up for their colonoscopy, half prepped and not prepped or whatever. The cost of having to reschedule that colonoscopy, never mind the inconvenience to that patient and all of the stuff that they had to go through for doing this, is just doesn't make sense. So it's very critical that you think of what you should have a human translator. And some people actually said, well, websites can be Google translated, or maybe websites are benign and they don't have any complex medical information on websites from the hospital. I beg to differ. I've been on some websites that actually have instructions embedded in them that are clinical instructions, so patients have easy access to them. So you really have to reevaluate and do a gap analysis of what your organization's at and what you think. But the high risk things are consents, discharge instructions, any consent, whether it's for hepatitis vaccine or whatever, and then also any intake forms and notices of what you require people to do if you want a response. You best make sure that the AI translation has been reviewed. So that's the best I can give you for now, because I honestly think it should all be reviewed. But if you have to choose a few.
Well, it seems to me that as these technologies become more common, it almost will, it's the technology itself will lead to greater human oversight if, there's compliance with this, because I think there will be more text that is being translated automatically as these tools become more commonplace. I would imagine that there's already a technology, if not being piloted, being developed, to take a picture of some complex document, send it to a different app, and it comes back in a different language. And that the speed of that, we've got the Trump administration coming back in. Will they have a different public policy view on this at all? What would a court say? What will patient advocates say the law requires? But as it becomes easier and more common, this tension of the ease of translation versus the importance of having a qualified human review it is going to be a big issue moving forward. So with that, I believe we're on the next slide. We're going to shift our discussion to still in the vein of technology, but we're going to move away from anything related to AI for now. We'll have questions at the conclusion of this. We'll take questions at the conclusion of this section. But new in the Biden administration regulation was this general prohibition. It's as general as the one that we just looked at with AI. A general prohibition against discriminating in the use of telehealth in a hospital or health system. So I've got the definition from the regulation of telehealth here on the screen, and it's very broad. The use of electronic information, telecommunication technologies to support long-distance clinical health care. That could include health education, public health, health administration. It covers video conferencing, using the internet, forwarding images, streaming, and wireless communications. And right below that, I've noted on this slide that telehealth is included within the definition of information and communication technology, which is itself identified as an auxiliary aid and service under the regulation. So it's a little circular, but not only does telehealth have its own definition, it's included as an auxiliary aid and service that we should be mindful of when it's used for deaf or hard of hearing patients. Next slide, please. So how do we, with just a general prohibition in the regulation, it doesn't get any more specific than what I've just told you. How do we talk about complying? Well, thankfully, a few years ago now, the Department of Justice and the Office of Civil Rights at HHS issued this guidance here that you see on the screen on non-discrimination in telehealth. And we're going to spend the next few minutes walking through some of the portions of this document. What I like most about this document is that it thinks holistically about telehealth, from communicating to patients about it, making it available, to thoughts around timing and who may or may not be, for lack of a better word, invited to use telehealth, to the actual use of it, the considerations around language and structure. So it comprehensively gives everyone on this webinar a lot to think about, to identify perhaps shortcomings or areas for improvement around telehealth. And this is a resource that will be a part of the resources that are associated with this webinar. So in the next slide, we'll start taking a look at some of these specific examples. So it starts off with some examples of challenges related to access itself. So if a telehealth platform doesn't support screen reader software, this would tend to discriminate against individuals with limited vision or who are blind, for example. So this is a disability access problem. Or if a certain platform doesn't allow interpreters to join remotely, which could have the effect of discriminating against limited English proficient patients in addition to deaf or hard of hearing patients, which would essentially require them to have secured their own interpreter to be with them in the same location. So that is another consideration. The instructions themselves on how to access a platform, if they are not in a patient's preferred language, if they're not accessible to an individual, that would tend to discriminate against these patient populations as well. So challenges in access, thinking about how do we promote access and lower barriers to access, is the first thing that this guidance discusses, and hospitals and health systems should think through these questions around access to telehealth as a starting place. Next slide, please. So I think for everyone in this webinar, this is likely very intuitive, but the other, starting with individuals with disabilities, thinking through how do you communicate in a telehealth platform to ensure effective communication with people who have disabilities, whether it's qualified human interpreters, whether it is some other text-based, but thinking holistically, or how you communicate to these patients in terms of when are providers available, how do you access your medical records, scheduling these appointments, and then the communications themselves during the appointments. These platforms, clinicians, staff, need to be prepared to effectively communicate with individuals with disabilities, again, at no cost to the patient, in a timely manner when using telehealth. Next slide, please. So this guidance then provides a number of examples of solutions or aids that can be used in a telehealth platform for individuals who are deaf or hard of hearing. For example, as we discussed, the platform should allow an ASL interpreter to join remotely. This would promote access. This would alleviate the burden from the patient to provide their own interpreter, and would be more effective. Just would make the appointment the most effective possible. Telehealth platforms, especially today with technology and AI, as it is proliferating, real-time captioning would be another tool to promote effective communication. And it's worth emphasizing, again, the use of a telehealth platform cannot inherently or intrinsically be used to put the onus on the patient to find their own interpreter or come up with their own technology fix, as if they should have their own application on their end to enable effective communication during the appointment. Next slide, please. And care should also be given to providing aids and solutions to people who have visual disabilities. So screen reader compatibility technology for web-based platforms. If there are demonstrations provided over the telehealth appointment, they should have captioning or audio descriptions, which is a best practice across any number of activities. And if, for example, a patient has a visual impairment, you may need to scrap the telehealth consultation altogether and engage in an appointment over the phone to accommodate that patient. Next slide, please. Of course, everything we're talking about applies fully to limited English proficiency patients. And so promoting telehealth, I'm sure many of you have seen this, the promotion of telehealth in social media or marketing or email blasts, that is not in any other language, doesn't have any other information about how to get access to the instructions in another language. That's something that hospitals and health systems should take steps to alleviate. And again, the platform should enable interpreter to join remotely and again, going back to training, if staff do not know how to use the platform effectively, then you could imagine a scenario where the telehealth platform doesn't promote access, doesn't provide meaningful access because there's a delay. It's not timely. It's not smooth. And that is, would render the telehealth appointment ineffective and not meaningful access. Next slide, please. Okay, so here, I think we have about 5 or 10 minutes for questions. I'll turn it back over to Matt, who hopefully we have some questions already teed up.
We do. Thank you, Drew, very much, and Carla as well for covering that section for us. Again, just a few housekeeping items as we cultivate the questions in the Q&A. So one, as a reminder, the recording of the session and the resources that are discussed in the session will be sent to all participants over the next few days after the session. So yes, that is coming to your inbox. If you have additional questions, please do post them in the chat so we can review them with Drew and Carla. So first up, we'll go with a question around the machine translation section of our time today. There was a question, Carla, if you would reiterate the 3 common or high-risk items. You talked about consent forms, discharge instructions. What was that third, and are there others that folks should be mindful of? Please.
I think the intake forms are critical. For instance, that's where I, as the patient, will document my medical history, for instance, right? Important things like allergies, important things like medication reconciliation. I know for a fact at my last place of employment, I wanted to really throw up, and I felt really bad for these patients because the pain clinic actually had a 17-page document for patients to fill out upon arriving to the appointment. I mean, it was like a nightmare for English speakers. Now, of course, none of those were translated, so you can imagine that the interpreters would be called to do site translations and spend up to 45 minutes filling out forms for patients, right? So wouldn't it have been great if we had some sort of AI-generated intake form that we could press a button and literally, we have this in several languages? Well, yeah, it would be really helpful, but it would have to be reviewed by a qualified human translator, because if not, you could have mistakes that prompt you to have questions answered, and you will take that to mean what it means in the English section, and it doesn't, and it could literally lead to very negative outcomes for patients. Consent forms are a big thing. Healthcare proxies, advanced directives. I mean, those are all sensitive topics to begin with, right? End of life types of things. No one wants to fill any of that out, but then when you're filling it out and it's nonsensical, it's going to really prevent people to complete that. And we really need people to be able to be autonomous and make their own decisions, right? No matter what language they speak. So I hope that helps answer the question.
Does. Thank you. Next question, back in the mitigation section of the decision support tools, Drew, you mentioned that more is becoming more and more common that health systems will have an AI committee or some such to review, the incoming technology or the technology already in play within the system. If one of our attendees was interested in trying to learn about that function or that committee within their own health system, what might some of the titles be to folks who you would assume are on that committee today?
So the titles of the individuals on that committee, I would expect include the chief medical officer, deputy, obviously the deputies. A lot of health systems are hiring AI officers right now. It's, a new and emerging role that is kind of built to be the chair of a committee like that, right? That would be responsible for comprehensively evaluating, analyzing, deploying, reviewing, purchasing AI tools. And that is an emerging profession all on its own. And given all of the healthcare specific considerations, the AI officer of a hospital or health system is likely, in my view, to have a clinical background, right? An MD or other experience as a clinician or a researcher to be in that role. But I think compliance professionals, chief compliance officer, the Section 1557 coordinator needs to be on that committee, and a legal professional, in-house legal professional needs to be on that committee. And I think then other ones that come to mind would include safety officer, quality officers. And right now, in my view, the committees are likely should be perhaps erring on more individuals. This is touching on every aspect of a hospital or health system's patient care experience and quality and safety, and obviously when you're talking about revenue or other financials. So because it could touch on so many different aspects of a hospital or health system's operations, it's hard to imagine who should not. It might be easier to say who should not be on the committee at this point, but those are the individuals that come to mind that could form the core of that type of committee.
Thank you
And
very much. Oh, go ahead, Carla, please.
I've also seen chief diversity officers, human rights officers, specifically with a focus on behavioral health, patient advocates, language access managers. Only one hospital that I know of has that as part of their AI committee. And, Drew mentioned that you really need to get involved in organizations to kind of like self-learn, right? You got to be hungry for the information. You have to be a sponge. Safe AI is a task force that I've been involved in that has really focused on creating a safe AI within healthcare, specifically focused on language access, for instance, as did the National Council of Interpreting in Healthcare, NCIHC, created a white paper for those of us that are in the hospital trying to kind of evaluate vendors that are giving us AI related things, whether it's translation, OPI, VRI, right? And you've got to ask the questions, because if you don't ask the questions, you're not going to know if you can ask for them to mitigate some of the risks, right? For instance, I asked a colleague of mine who's also a lawyer and said, why isn't the O2 SAT machines fixing what's broken with it? Well, because no one's asking, and it costs money to fix that type of thing. And if no one asks or demands that they mitigate the risks before you contract with these vendors, then you're going to get what you get. So I think that it's important to really be the subject matter expert on your niche of of work, whether it's language access, diversity, risk, behavioral health, so that you can bring something to the table and that you can be aware of this.
Great. I just got a follow-up question on this one, I think adds on. So the question is, has there been any guidance related to the recommended routine or frequency for monitoring these tools annually, semi-annually, quarterly, et cetera? As the organizations start to collaborate with more and more tools, the lift for monitoring seems to be growing exponentially.
I have not seen any sort of official recommendation, official guidance on that, or let alone unofficial coming from the federal government. I think that um, it's something the industry itself is grappling with. What does it look like for ongoing monitoring? Is it in real time? It seems to me that where the industry, there is a couple of different options. Taking a step back, you may have seen in the news that Republicans in Congress recently just sent a letter to HHS asking them to pause and reconsider their efforts to forming these government-sponsored assurance labs around the use of health AI. And these assurance labs were an attempt to create laboratories, groups that would test, validate, monitor health AI, and kind of with that stamp of approval, it can be used in a trustworthy way, and there's a documented way of using it and monitoring it that has quasi-regulatory approval because it's a government-backed lab. Well, the concerns in the letter, everyone should read it for themselves if they're interested. This is the classic problem of, are we promoting regulatory capture? Does this invite the developers to have too much sway in the process? On the other hand, is this at the risk of stifling innovation? Is this too heavy-handed to have this type of assurance lab? And so I use that as an example because it's very timely. This letter went out last week, but everything's kind of in flux. There's not a clear policy, especially with an incoming change in administration, on these issues. It seems to me that ongoing monitoring in a more real-time basis that invites complaints to be surfaced in real time, concerns to be surfaced in real time, coupled with periodic validation, periodic testing of some increment that's likely to be identified as a best practice at some point in the future, whether that's 3 months, whether it's 6 months, a year, of validating, revalidating these tests, recalibrating the technology or something like that. So right now, there's not a very good answer in my mind to offer to that question.
It is certainly dynamic for sure.
And Matt, I would add one more thing to that, just for those of you that are, most of us have policies in hospitals, as Drew had referenced. Be careful. Be careful because you're going to be held to what's in your policy. So I love the fact that you should be evaluating any complaint, any grievance, any incident, any safety factor in real time. But if you put down in your policy that you will do a deep dive to evaluate or reevaluate biannually, then you'd best do it. So be careful of what you put in your policy because that's what people are going to look at when they come to visit. And if you don't follow your policy, then that's a real issue.
So I'm going to move to 2 telehealth questions, and then
Sure.
there's an EMR one, and I think that will probably conclude our middle Q&A section. So the first one on telehealth is a very specific example. So our audience states they're using an online history and physical capture program that's completed by the patient and then transmitted to an ambulatory surgery center. Is that considered telehealth?
I believe it technically would fit, yes, the broad-based definition that we looked at earlier. It's not video conferencing, but it's transmitting, information wirelessly, which is broad enough to encompass any of these type of distance-based communications that are going on between a provider and a patient.
Follow up on telehealth. So the telehealth rules today seem to not cross over into billing. Will that come eventually?
So that's a very interesting question. I think that seems to be implicitly outside of what we just discussed. I have not seen an indication that conversations around billing that may take place in a video conferencing platform would be a telehealth type visit or appointment, but it would fall more generally. This won't be all that helpful to everyone listening, but anything that a hospital or health system does is covered by these broad-based prohibitions on discrimination. So a billing conversation implicates effective communication, language access, and you can imagine risk or discrimination or a barrier, a significant one, depending on the nature of the conversation, especially if a bill needs to be paid before additional services can be rendered or scheduled or something like that. Just because something might fall outside the text of the regulation does not mean it is not implicated by these laws.
Okay, two more. This is an EMR question around machine translation. So, speaking of access to the electronic medical record, what can you do, or what suggestions do you have if the EMR does not support the script of a specific language and the company has no plans to expand the language capabilities in the platform?
Okay, so I'm going to get into translations a little bit further on in my discussion. But I mean, with over 6,000 languages in the world, more than likely we're going to encounter that quite often. And these EMR companies are now just starting to really get robust enough to provide language assistance in the EHR itself. So more to come on that.
Good, thank you. And then
Yeah,
one final
Matt.
transit. Oh, go ahead, Drew.
Oh, well, this is a perennial problem that is, I believe, as Carla is indicating, one that the industry is aware of, the vendors are aware of, and there seems to be an improvement of collaboration to export information and get information out of an EMR and into a different language. But that's something that hopefully there's additional progress. Matt, I have one question after your question. Okay, so if you could throw it back to me when you're done.
No, go ahead, Drew. You're good. Go ahead.
Oh well, so I was going to ask Carla to weigh in on our discussion of the telehealth because I failed to do that before we went into the Q&A, and I would be curious to hear Carla's perspective on some of the telehealth guidance that we summarized, whether that was adequately concrete for compliance professionals, if that touched on what she considers to be the important issues, or if she had anything to add to that discussion from an operational basis.
So I was involved in several platform integrations with telehealth, and I will tell you that, initially it's always an afterthought about language access. It's like, oh wow, what do we do with people that are deaf or individuals who are limited English? So I think you covered most of the things. The thing that I would spend a little bit more time on is none of this matters if the patient is not provided training materials or translated documents on how to even connect, how to even navigate a computer. Some of them do not have computers at home. Some of them can do it on their phone. Some of them don't have Wi-Fi. Not everybody has access to things, right? So I think that providing the educational material to the patients is vital because it becomes a one-way, yeah, we know what to do, but the patient can't connect with us. The other thing that I would say is that one of the most seamless integrations I actually worked on happened to be with AMN because, in all honesty and transparency, they were my a partner and my vendor of choice for many, many years. And what I liked about it is that the provider got the interpreter on before they connected with the patient. So it was kind of a warm introduction with the patient versus the provider coming on the screen, like I've seen on so many other cases, and going the slow and loud version of wait, interpreter coming, that type of thing. So it's small little things that facilitate the ease and the comfort of the patient. Because in all honesty, for most patients, interacting this way is not what they're used to.
Yeah.
Well, and I think the surveys and the data bear that out, that limited English proficient patients and deaf or hard of hearing patients consistently report lower satisfaction with telehealth appointments. And that's probably one of several reasons why that would be the case.
Correct.
I appreciate your feedback on those, guys. Thank you. For our participants today, I'm sorry, for our audience today, please do continue to add questions into that session. We will continue to curate those. But I'd like to now pivot over to Carla, please, for your content for our session.
Excellent, excellent. Let's see if I can add to the discussion a little bit here. Give me 1 second. My computer is freezing up on me. So during our first session, I covered the responsibilities of the Section 1557 coordinator, along with the requirements for a non-discrimination notice and policy. Today, as Drew said, I will focus on language access and effective communication procedures. But several of you did reach out after the first session with questions, which I was very pleased, but you were requesting more emphasis on operational best practice. Like, how do we put this into use? I'm overwhelmed. I don't know where to start. I plan on addressing this in detail today. And then in our final session, Drew and I will cover the grievance procedures, reasonable accommodations, and staff training, followed by the remaining hour, hopefully dedicated to an interactive Q&A session. So please think of your questions. I'm sure you have quite a few, and I'd like to be able to answer them while we're here. So to revisit Drew's opening remarks about what I call the yo-yo effect, and you all know that a yo-yo diet does not work very well, we often see this yo-yo effect with each new administration. So let's just take a step back and consider the broader picture. Legal and regulatory requirements are not solely based on the ACA Section 1557, thankfully. There are many existing longstanding laws, as Drew mentioned, like the ones on the slide here that remain unchanged, and some of them have remained unchanged in 60 years. The Civil Rights Act, the Americans with Disability, the Rehab 504, the national standards, the class standards, the HIPAA law, the Executive Order 13166, CMS. And let's not forget, additionally, that you must comply with standards from bodies like the NCQA for accreditation, the Joint Commission, or DNV. So for those of you thinking of, let's wait to see how the current administration handles things, it's important to remember that these requirements are currently in place, and your organization is accountable to meet them right now. I mean, I don't think most people are aware that anyone, it doesn't have to be the patient, can file a complaint with the Department of Justice, even anonymously. So why would you take the risk? You know, there's a whole thing that I have had numerous discussions with a lot of senior leaders, and their statement is that LEP patients typically do not file complaints. Well, they don't have to file complaints. Others can do it on their behalf. I was involved with a hospital where a nurse from the ER actually filed an anonymous complaint because she felt that the patient was treated so atrociously. So again, chances are many of these compliance measures are already in place in some fashion within your organization. It could be, what I would call lightly placed, and they may just need some adjustments or some augmentation. So keep in mind that you still are responsible. And I honestly hear what Drew says. Drew thinks it will be a year or so. I actually think, just based on talking to numerous people, that it could be longer than that. And again, language access was not touched last time. Some of the administrative things were. What's going to be really interesting is what the oversight's going to be, what the ramifications are going to be if you break, if you're not compliant. So ensuring compliance is not only providing a safe delivery of care, but it also helps to, where it matters for most people money-wise, it reduces readmissions. It minimizes negative outcomes for the facility and for the patients, decreases your liability, and ultimately, think about it, it supports the ethical and right thing to do for your patients and for your staff. Next slide, please. So some of you asked about, how do I create policies? I have some of these policies. I don't have all of these policies. Or my policies are so old that, they go back for 20 years. Well, there's no need to create any policies from scratch. HHS has created some sample policy templates that really outline criteria that these inspectors may be looking for if they come to visit. So compare your organization's existing policies with these, identify and address any gaps, and incorporate those into your policy, but make sure you look at the size of your organization, the scope of what you do, and be pragmatic. Do not create something that you cannot deliver. And AMN will also provide numerous samples of existing policies, including one that I wrote that are publicly published for reference. So, you may want to look at that and say, oh, I like the way that's phrased better, or that seems to make more sense, or we were doing something that was, from a flowchart perspective, not as easy to follow. So if your organization lacks a policy, I suggest you create one using the HHS templates, tailoring it to you, and for multi-state organizations. So for instance, when I was Section 1557 officer, it was 42 hospitals across 11 states and about 3,000 physician practices. So for me, a standardized policy is preferred. So I had one standardized policy, right? But, it doesn't always fit for everything, right? So the reason I like the standardized policy is because my training materials, my resources, everything could be, it was easier to do, to be honest. But each individual location may require an addendum to the policy to outline where do you reach, how do you access interpreters? Where do you keep the translations? Where are the auxiliary aids and how can I access those? Because they may be different depending on what resources you have available of interpreters on staff, translators on staff. Maybe you're in a rural area where you literally do not have an ASL interpreter, like one of my clients, within 4 hours of driving. So you have to have all that outlined in your addendum. So they'll follow the standard policy, but then the addendum will be specific to that location. And then what I didn't mention before on the previous slide is that you should cross-reference state laws, right, during creating your policy, because what I did not realize is, oh my goodness, how many different laws. You can go to NHELP, which has a book of resources of 50 states and every state law that's language access related. It's been incredibly helpful for me. So in cases where state laws impose stricter requirements than federal regulations, make sure that your policies comply with the ones that are more stringent. So if it's federal law that's more stringent, comply with those. If it's state law, comply with those. And then again, most of us have a policy review of like every 3 years. Some hospitals do it every 2 years. Some do it every 3 years. Some clinics do it every 4 years. But establish a mechanism to ensure that these policies are updated regularly and effectively implemented. But by implemented, I mean provide the training across the locations. And then I cannot emphasize this enough, train staff on any updates. And within 30 days of the implementation updates as required. So for me, it was a logistical nightmare every time we had to make a change to a policy. It had to go to a policy review committee, then it had to go to patient care provision committee. And, by the time it got finalized, honestly, there were more changes that I needed to make to the policy. So think carefully of what you want to put in your policies. Less is better sometimes. I mean, some organizations have policies that I've reviewed that are 15 to 20 pages long. Again, that's a lot of things, and no staff person is going to be staring at that and looking for what they need out of that. So what I also did was I took my policies and I created a job aid from them. So I summarized key points, and we called that a job aid for language access, a job aid for auxiliary aids, a job aid for LGBTQ. We had several job aids that were really helpful. And you saw the samples of the policies, and there's a lot more resources on the HHS site. So please refer to those. Next slide, please. So the notice of availability of language services and auxiliary aids, a common mistake made by many organizations is the failing to provide meaningful access when posting these notices. So it's almost like, okay, I need to do this, so I'm going to wallpaper my hospital with all of these different notices. However, during my gap analysis for various organizations, I often conduct a thorough review of their websites. While I frequently find translated notices into the top 15 languages, which is commendable, and more importantly, it's required by law, these notices typically only list one single phone number for all languages. So for example, honest truth, I just went to a recent visit for routine lab work. And of course, I'm a snoop. I'm paying attention to patient rights being translated, and there's a notice there that's in the top 15 languages. But this notice provided one phone number, an 800 number, for all 15 languages. And when I called as a Portuguese speaker, the line was answered in English. I spoke in Portuguese asking for help. And after numerous, and I mean numerous back and forth transfers and a 22-minute wait, I was finally connected with a Spanish interpreter instead. So Drew, this to me is not meaningful access. And most people would have like just dropped the call and just, thrown their hands up in frustration. But I think I know we can do better than this. Next slide, please. So here is a sample of the pre-translated availability statements. And it basically is right from the reg, and it gives you everything you need to know as to what you have to have in place, but you do have to have a contact number in there. And what I have found after reviewing these notices, and I'll be completely honest with you, some of them are from people who are on this call today. I actually went to some of the websites of the registrants just so that I could be helpful to you. Take a look at some of them, because some of these actually stated that these services will be available at the front desk or emergency room. Some are missing the English version. Several had no contact phone number. Some don't have anything on their website. And in one case, it connected me directly to the vendor. And the vendor told me in English to call again after hanging up on me twice. So, and one actually very interesting fact is that there were several that actually on their website provided their vendor's 800 number with the PIN so that anybody could actually use your account and rack up, charges on it. We had this happen at one of my hospitals where a competitive hospital, a doctor left, and in his own practice, he took my 800 number and the PIN and was utilizing that in his practice. So be careful where you post this, but make sure that at least you have a contact phone number. So to improve this process, what I would recommend is to establish an auto-attendant voicemail box for at least your top 3 languages that are spoken by your patient population. This would allow, if it's Spanish, Portuguese, and Haitian, for instance, this would allow patients to leave a message in their preferred language and then receive a call back from you with the appropriate interpreter already on the line. That is really patient-centered, right? For all other languages, as I mentioned, we have 6,000 of them. You can't have a box for every language, but maybe a general English voicemail box could be used with additional efforts being set up to identify the language before following up. And this all requires extra work, right? And some operational adjustments, but it significantly enhances meaningful access and ensures a smoother experience for LEP patients. So on the right-hand side of the slide, you will see that HHS has also, I want to commend them. They actually have done a great job in providing resources. They actually have given us 48 translations, 48 languages translated. In the old days, because I'm a fossil, in 2016, when this came out, you have no idea how much money I had to spend on translating a lot of this stuff. And then, the hospital across the city was doing the same thing. This has actually been a great effort for them to be able to help hospitals put things in place without being an additional burden. Next slide, please. So the notice of requirements of availability of language services and auxiliary aids require that you provide it in English and the top 15 languages of the state. If you don't know what your top 15 languages are, CMS actually, if you do a search for CMS top languages per state, will provide you with that. The font has to be the minimum 20, at minimum, It could be larger, 20 font sans serif. This is for people, this meets the ADA standards. And it has to be available annually to the patient and upon request. So if a patient asks you for it, you're supposed to be, giving it to them. Displayed on the entity's website in a prominent place. By the way, when I was telling you that I reviewed some of the websites, I had to go through 3 clicks. Like, usually it's down at the very bottom of the opening page. It says non-discrimination, language access, etc., in fine print at the bottom. In some of them, I had to literally go to 3 different areas before I found anything. Also make sure that you display it in prominent areas, physical areas, in size 20 font, or larger, and have available alternate formats to individuals requiring auxiliary aids. And we'll go into that a little further. So also, the new update is that the usage of this, you have to include it in certain electronic and written communications. So notices of benefits, notices of patient rights, notices that require a response back, you need to make it available. Collections, billing, the No Surprise Act, when people get a good faith estimate of what their costs will be for their surgery, it has to be included in that. Consents, discharge instructions, member handbooks, public emergency information, like when we went through COVID, it has to be available in that. Complaints and grievances, and this is not an exhaustive list. Also wanted to give you a little heads up that when I went into some of the websites, I found the complaint section, but instead of having a section 1557 officer or patient advocate or somebody internal, it sent them right to Joint Commission or to the state of California to file a formal complaint. I would think that you'd want to preempt that and see if you could mitigate and resolve the issue, because it could be something simple that you could do. But, just take a look at what's out there. And on the slide, you'll see that AMN has prepared, this is for the state of Alabama, the top 15 languages, and it includes the auxiliary aid statement right at the very top. The top 15 languages for the state of Alabama, plus it has the ASL symbol in the right-hand corner, if you see it right in the green. So I think that that is incredible. They also have it formatted so that it will print well in a size 20 font. So literally, when I spoke with folks at AMN, I said, I want you to make this so easy for me that I don't have to think about it. And boy, did they rise to the challenge. Other states are going to be released. So they'll have this for all the 50 states, and they'll start with the states with the highest percentage of LEPs, and then they'll release it. So more to come on this, but very excited because I had to do this all on my own, and I had to pay for all the translations, and this is really a nice added value. Next slide. And by the way, this has to be in place no later than July 5th of 2025. So some of us already have similar things, right? We may have a language access poster or just a language identification poster like you see here on the right-hand side. This is an example from the state of Massachusetts that has a lot of requirements for language access, thankfully. We're grateful to them because they have really moved language access to the forefront in Massachusetts in many ways. But the one thing that I will urge you to do is no matter what you use, make sure that you have an ASL symbol in it. It won't be your top 15 languages, but add it as a 16th. Be inclusive. Be aware that this will help with the ADA requirements as well. So again, post this in prominent areas. What does this mean? I cannot begin to tell you how much I detested having to have patient rights, HIPAA, notice of discrimination, EMTALA, all of these things in 3 to 4 different languages at each hospital. Literally, we were wallpapering the walls and we didn't have space all the time. So try to consolidate as much as you can, but make sure that you put these at every patient entry point. So any door or entryway, lobby, emergency room that a patient would walk through. I used to call these the room service walks, come in from the parking lot and figure out every place that a patient would walk through on your off-campus locations, on your, main locations, and put this in a prominent place. For me, the easy way to do this was to put it in front of every patient elevator. So if a patient was going to use an elevator, as soon as they stepped off the elevator, it would be prominently displayed there. So presumably they had to see it and no one could miss it. And that actually got me out of hot water more than once when people would made allegations that they were not aware that we had interpreter services available to them. So just a gentle reminder, though, that when you post these in behavioral health units, please make sure that the frames are not in glass. I know of a hospital that had a very unfortunate incident about this because they told facilities just to post these in these areas, but no one really made sure that it was in plexiglass or nothing, no cover at all. So next slide, please. So a couple of other things that I wanted to give you as operational resources to help identify and support LEP patients or deaf patients are very practical tools, and some would say that they're very old school, but they're very effective. So for instance, we utilize the International Interpreter Symbol, which is the three speaking heads that you see in the picture here. And we would put this magnet right on the metal door jamb of the patient's room if they identified as an LEP or a deaf patient. So most of the hospital door jambs are metal, and this worked really, really well. It was small, it was unobtrusive, but it was visible. And this visual cue, ensured that staff immediately recognized the need for language assistance. So if I was a hospitalist, a phlebotomist, a dietitian, somebody delivering trays, I would go and see, okay, this person that I'm going to see needs language assistance. Additionally, we equipped each of the patient rooms with when an LEP patient was admitted or a patient who was deaf, LEP patients would receive dual handset speakerphones at their bedside, and patients who were deaf would receive an iPad for VRI communication that would remain at their bedside through the length of their stay, which gave patients such relief from anxiety of how they were going to communicate. And then on top of that, we would look at the patient's whiteboard and we document the patient's preferred language very prominently. So hospitals would walk in, see the magnet, look at the patient's bedside, see either the iPad on a stand or see the dual handset phone. And then they would look at the board and they would know what the language was. And within seconds, they could connect to an interpreter, and it could be hands-free on speaker. So some of you may have 2 bedrooms and some of you have single rooms. I can assure you that after many, many discussions with legal, HIPAA, and everybody that was involved, it's no different in a 2-bedroom. That little magical curtain does not prevent the other patient from hearing your discussions in English. So there's no privacy issue by using the speakerphone, so you're hands-free, so you can examine the patient, you can do your documentation, etc. And the whole purpose of this is to make sure that these measures made it significantly easier for providers to engage in effective communication. Even something like leadership, they do their rounds. Leadership will, they'll do their little rounds and check on patients. Well, they didn't even have to think about it. They didn't have to go grab an iPad or grab an interpreter. They would walk in and seamlessly be able to communicate with the patient. Some of the hospitals are doing bedside handoff communication shift to shift. Well, it was amazing to me that common sense really isn't common. The nurses were standing at the patient's bedside, talking to each other about the patient without having an interpreter present, either in person, on the phone, or through an iPad. And this is supposed to make patients feel better, more involved in their care, autonomous, and being able to ask questions. Well, all it did was increase the paranoia of the patient and make them very uncomfortable because these 2 people were talking about them, obviously, but they were not in the know. So on the screen on this slide, you'll see a couple of other examples called I Speak cards. And these I Speak cards are little wallet cards that, fold up. And where it says I speak, we would enter the patient's language. And then it says name, date of birth, and maybe medical record number. We'd either put an addressograph label on it or we'd fill it in so that when the patient presented to us, they could show the card and it would facilitate us being able to figure out what they were there for and where they needed to be. And it gave the patient a real relief that they were requesting an interpreter. So something as simple as that, it's very low cost, but it really makes a lot of sense. I had a competitor hospital once call and say, you have a patient that presented here with this card from your facility. What do you want us to do? Honestly, I wanted to say, send them back to us. But, isn't it great that the people are being innovative and using this to go to pharmacies? People were using it at pharmacies. They were using it at different things because they could identify themselves and what language they spoke. And then on the right-hand side, many hospitals have these little slide-in things where you can put NPO or whatever you want to put for a patient. And you could also put the interpreter symbol interpreter. I don't like these as much because frankly, they're difficult to get in and out. And remember that once these patients get discharged, you have to remove these items. If you have to remove the dual handset phone, you're going to have to disinfect that per manufacturer instructions. Disinfect the magnet so you can reuse it for the future patients. So just some ideas for you to be a little bit creative because that's the struggle. Providers were saying, oh my God, I walk in, I start a 5-minute discussion with the patient, they're nodding, and then I realize they don't speak English. So this was a real satisfier. Next slide, please. Another best practice, and actually this signage, we won a couple of awards and commendations from Joint Commission because it informs patient of some of the auxiliary aids that may be available. Patients will ask for things if they know they're available. So this one would show ASL, it would show interpreters available, it would show hearing amplifiers, video phones, large print material, TTY phones, closed caption, again, with the braille underneath. Okay, so we would place these in significant areas where people would utilize them. But keep in mind that braille signs must be installed so that the tactile characters are located 48 inches to 60 inches above the finished floor, because that's when it will work. You would have no idea. Some of these things were like 6 feet up. Some of them were like 2 feet from the ground. You have to make sure that they're in the right place. I had a facilities gentleman that I love working with that wanted to surprise me by posting these right at the entries, but our doors were sliding doors. And unfortunately, you put it on the door that the other door slid over. So again, they should be at the registration areas at the point of entry, but basically near the desks so that if somebody comes to a desk, and they can actually request what their needs are. And then one other thing that I've been seeing a lot of, and it's such an easy thing to fix, is closed captions have to be on per ADA requirements on every public-facing television. So anything in the waiting rooms, in the cafeteria, in the lobby, in order to meet ADA standards, okay? This is something that's so easy to do, and it can easily be addressed and avoid some of the grievances that I have had to deal with. Next slide. So another tool, and this is one you can create, certainly don't have to utilize this, though we've given this to you as an example, and you'll have a link to it, is a language ID poster and disability accommodations. So this is laminated, double-sided, it's 8.5 by 11. And some people put it right at the desk so that patients can point to it. We recommend that you really need to know what the patient's communication preference is, what language, so it's effectively communicated to all staff. So having this available at every registration desk, information desk, security, every department, x-ray, whatever it is, and all of the nursing units is really fundamental so that patients, you should know their language, but believe it or not, sometimes the language that registration captures is not the correct language. Companions and visitors can come up and identify their preferred language. So, it's so frustrating. And I tell you this because I've had numerous focus groups with patients. Patients find it so frustrating and exhausting, especially our patients who are deaf, to repeatedly have to explain their needs to every single staff member they encounter. It's exhausting. These people are sick. They're not at their best. And yet they're the ones that have to kind of keep you abreast of what their needs are. So once they've identified it, please make a process, address a system where communication preferences are clearly documented, and whether this is part of the communication handoff process or prominently displayed in the patient's electronic medical record. This just ensures seamless care and improves the overall patient satisfaction. And equally important, it avoids people like me that are clinical from making blunders and not providing the patient with what they need as equitable care. On the very back of this, it's got a disability accommodation resource, which says I'm hard of hearing in my right ear, left ear. This is what I need for effective communication. I'm deaf, I'm low vision or blind. And I have to tell you, the nurses gave me a little bit of a hard time with this when they said, well, geez, if I'm blind, I'm not going to be able to see this. But there are lots of people that are legally blind or low vision or have some sort of degeneration of their eye. And this was extremely helpful. So we also had created a sheet where once this was identified, this would go with the patient's chart to every single department. And this is how we did it because we didn't have a way of putting it in the EMR at that time. Next slide. So we're going to go into the written language access procedures. Next slide, please. So the requirements are, right per the regs, a covered entity must implement written language access procedures in health programs and activities, describing the covered entity's process for providing language assistance services to individuals with limited English proficiency. Sounds pretty simple, not always simple to do. And I would encourage you, when you write your policy, give it to someone that is new to the organization to follow the steps. Give it to somebody in registration. Give it to somebody on the night shift that may not have all the training, and ask them if they can follow the process. And if they can't, then you have to revisit that. Next slide, please. So they also must take reasonable steps to provide meaningful access to each individual with limited English proficiency, including companions with limited English proficiency eligible to be served or likely to be directly affected by the health programs and activities. So again, it really annoys me that I've had to have these conversations repeatedly with hospitals and with providers. We had a recent encounter where a patient who was hearing was delivering a baby, and she had requested an ASL interpreter for her husband, who is deaf. And the hospital refused to provide him with an ASL interpreter, quoting that she was their patient, not him, and they had no responsibility to provide him with services. That did not turn out good for them, let me tell you. So you are mandated to provide these services not only for the patient, but visitors, companions, family members, friends that come. So please, please keep that in mind, okay? This is not just for the patient. Next slide. So what is required with the written language access procedures? Well, the general requirements is, again, have a identified Section 1557 coordinator with contact details, and you do not have to provide the name. Please don't put the name in there because it changes. And I would recommend, if you can, establish a pseudo email that says Section 1557 compliance or whatever you want to call it, so that it stands out differently than the emails, the hundreds of other emails that you receive, and nothing falls through the cracks, okay? Again, the LEP identification process, I showed you some of the tools that might be helpful in doing that. Steps to obtain qualified interpreters, and we'll go into what's qualified interpreters and translators next. Bilingual staff, you are now required to maintain a current list of qualified bilingual staff. I call it QBS for short. That's what I used. I mean, feel free to use that, but it just tells you what you need to do. It's right from the language. And then also the translations, you have to have a way for people to access the translations, whether they're electronic or written in hard copy. You have to maintain a list of all these translated materials, both electronic and printed, by language and the date that the translation was issued. So 2 key points, and I'll talk about how best to do that in a moment. And then auxiliary aids, guidelines for requesting and utilizing services for individuals with disabilities. And most of you have some format of this in place, I hope, but this is due no later than July 5th, 2025. But remember that if you create these policies now, you have 30 days to implement them and do the training. So we'll talk about specifically deep dive into staff training at the January session, but Let's go into the reasonable steps. Next slide, please. So what must be provided? Meaningful access for individuals with LEP. So it includes the providing of interpreters, the providing of translations, publishing these notices that are required about language assistance in the top languages of the state, offering qualified interpreters free of charge and in a timely fashion. That one always gets me. What is timely? One hospital thought that timely for a Russian interpreter was 4.5 hours. And it didn't make any sense because they lived in a large Russian community. So you've got to also look at that. Is it a language of rare diffusion that maybe it's Igbo and there's only 2 Igbo interpreters in the whole state? Maybe your language service provider doesn't have Igbo available 24/7. I mean, but if it's timely, timely means without undue delay to medical care. So, you've got to really think about that because if I, as an English speaker, could tell you my level of pain, I could tell you my allergies, I could tell you why I'm here. And yet, as an LEP, I'm waiting an hour or whatever to get that same message communicated to you. That is an issue. And that could be a reason to file a complaint. So next slide, please. So what can't you do? Prohibitions. You cannot require individuals to provide their own interpreter. It's amazing to me that patients will show up at a physician's practice and they will be turned away and said, I'm sorry, but you have to bring your own interpreter, especially our deaf patients who are deaf, because they'll say, well, we're not going to pay for it. Are you going to pay for it? I mean, it's atrocious what people are going through. And a lot of it, honestly, in my heart, I believe it's because people really do not know what is required from them legally. And it's a lack of knowledge. At least I'd like to believe that, okay? So don't rely on minor children unless it's a life-threatening emergency, and only until a qualified interpreter is available. And you'd best document all this. Preferred interpreters when there are concerns about confidentiality or conflict of interest, adult and family members. And I'm going to go into this really deep at the next one for staff training, because this is the one that usually I get a lot of questions about, and also a lot of high-risk situations. Do not provide unqualified bilingual, multilingual staff providers to service interpreters, and of course, the low-quality video remote interpreting services. So if, as a last resort, you must temporarily rely on a child to interpret while securing a qualified interpreter, it is crucial to document all your attempts to obtain appropriate language services. So, 10:05 contacted first LSP, no interpreter available for Igbo. 11 o'clock contacted second LSP, still no interpreter available for Igbo. Document it, because without documentation, you have nothing. I once had a physician use a child, an 8-year-old, to ask about her mother's vaginal bleeding. Okay, only because he was in a rush. He had to get to a soccer game. I mean, it's deplorable. And there was a complaint and an investigation, and he did not come out on the winning side. So again, another common challenge arises when family members or friends are asked or volunteered to interpret. There are so many reasons to avoid this practice. It's important to remember, though, that patients ultimately have the right to make their own decisions, including refusing the qualified interpreter, just as they can even refuse life-saving care, okay? But that doesn't matter if they use their cousin Tony to speak for them or to interpret. Ultimately, you are still responsible for all of the communication. So to address this, you should establish a very clear process to mitigate these situations and ensure compliance with the legal and ethical standards. But we will dive into the specifics of managing these challenges during our final session in January as part of the staff training piece. Next slide, please. So what is the difference between qualified bilingual staff, qualified interpreters, and qualified translators? So basically, the qualified translators, interpreters have extensive training in ethics, standards of practice, client confidentiality, and people who are qualified bilingual, multilingual staff, like I'm a Portuguese-speaking RN, may not have that. So bilingual providers and staff are considered qualified when providing language assistance as part of their current assigned job responsibilities. So if it's not in your job responsibility, maybe your job description needs to be altered if you become a qualified bilingual staff to demonstrate that, so that if something goes wrong, it's not like you were doing this ad hoc. And you can only do this if you've been tested or credentialed for their clinical fluency in that non-English language. So for example, if I can explain an A1C result to an English-speaking patient for 20 minutes, then I should be able to do that at the same level in Portuguese. So we need to make sure that these bilingual providers have clinical fluency. And if these bilingual providers and staff are utilized to serve formally as interpreters or translators, then they must complete the whole training and adhere to the interpreting ethics, conduct, and confidentiality, which requires formal interpreting and translation training, okay? And in some cases, certification. So if you're accredited by the Joint Commission or even DNV, make sure that you perform annual competencies on the interpreters and on translators on staff, no different than you have to from other disciplines. They will ask to see it, and they will ask to see the training involved. They will also ask, how did you assess this person for their fluency, for their job skills? So please make sure that you develop a competency, and we do have a copy of one that will be shared with you as well, if that's helpful. Next slide, please. So this is just an example that I wanted to give you. I recommend establishing a system for identifying those who are credentialed as QBSs. So this is a sample ID badge. It identifies me as a registered nurse, my ID number, and that I'm a QBS in Portuguese, for instance. I like the term credentialed versus certified, because its certification implies something completely different. It also helps with auditing by allowing you to easily track whether the staff is complying with language access policies. You're walking down the corridor, you hear Betty talking to a patient in another language clinically. Does she have the badge that credentials and allows her to do this? It makes sure that only qualified staff are providing clinical care in another language, both helping with maintaining regulatory compliance and patient safety. One of the hospitals in Massachusetts had Joint Commission visiting when, unfortunately, she heard a nurse discharging a patient in Spanish. She asked the person that was, accompanying her from the hospital whether that person had been vetted or tested, and unfortunately, they had not. So they had a corrective action plan where in 45 days they had to get everybody tested. So again, make sure that you have a process in place. Next slide, please. So implementing this testing process in my previous place of employment was a significant challenge. It really was. It left me black and blue, especially given the initial resistance. However, outsourcing the process to people who are qualified and objective professionals with vetted testing practices made all the difference. This was not Carla Fogaren that did not like this doctor and failed him. This was absolutely neutral. It was done without bias. In my case, nearly 8,000 employees were tested and 40% of them failed the assessment. And I have to tell you, the assessment was not difficult. So the vendor that I worked with actually happened to be AMN provided detailed credentialing documentation, which included individual performance outcomes, as well as areas for improvement for those who did not pass the assessment. So my recommendations based on my experience are for the employees who pass, share the results with them, and review what it means to be a QBS. Reinforce that they're prohibited from serving as interpreters, but can provide care in another language within their scope of practice and license. For clinical staff other than NPs, PAs, and MDs, file their credentials in the HR personnel file if they pass. And for NPs, PAs, and MDs, they go to the medical staff office. Okay, this will be essential for proving qualifications during visits by the Joint Commission or DNV, or for legal purposes. And for employees who do not pass, do not file the results in their personnel file. They perceive this as it could possibly be punitive. It may negatively impact their evaluations. It makes them really anxious. So I would not file them, and I would provide constructive feedback based on the areas identified for improvement, and perhaps allow them to retake the assessment 6 months to a year after. So this is what I would recommend. Next slide, please. And I mentioned to you, you have to keep track of the qualified bilingual staff. And also you have to keep track of all of the translations. So to meet this requirement, I would probably place a hyperlink in the policy to a portal that you should ask your translation vendor if they can create a portal where a repository where all of your translations could live. That way it could be accessible at any time, night shift person, weekend person, per diem person, by clicking on the link. If you cannot do a portal, then I probably would state that in the policy somewhere that you would have a list of qualified bilingual staff and translations updated biannually. This way you're not constantly updating the policy, which we know is not easy to do. And translated documents should include the following: the date issued. The actual specific regulations say not date of translation, but date issued, and revision dates, and the language should be identified on the form. I recommend putting this in the footer so that the nurse knows she's giving the Portuguese one versus the Spanish one, or as one nurse said, it all looks Greek to me. So you would have it clearly identified. And then discharge instructions still remain one of the challenges that we have to deal with. So if possible, again, to the previous question earlier, integrate your EHR with your language service provider. So I believe AMN is integrated currently with Epic and Cerner and is working on Meditech and a few others. This would allow certain aspects like the after visit summary, known as AVS, to be translated. Other aspects like the patient portal, which is absolutely necessary for meaningful access, right? We don't have a lot of time or any time to honestly go into this further today. If we have any time at the January one, I will cover a little bit more on this. If you do not have the integration, then best practices is to pre-translate all major discharge instructions by qualified translators, and that anything that's customized, because you know there is, the doctors will customize something for a particular patient. You could do one of the following things. You could have an interpreter present to interpret that to the patient with a provider. You could have a qualified translator if you have one on staff. Do it in real time, which is a challenge. Or you could utilize machine translation and have it reviewed by a qualified human translator just to reduce the amount of time and the volume of work. So those are three options that you can utilize. I've never utilized the last one because we had the other options available. So anyway, so next slide, please. And a couple more tools for auxiliary aids, like people felt overwhelmed, like we don't even know what they are. Like note takers is just somebody to take notes, you know, but qualified interpreters, etc. This is so old school that some of you are probably like gonna break out in giggles, but it's a toolbox. It's just a file box. And we used to call this the auxiliary aid toolbox, or some people call them the interpreter toolbox. And we would put things in it like magnification lenses, signature cards for patients to sign that are low vision. They can sign consent forms, etc. Readers for patients, hearing aid batteries, language identification posters, all sorts of things that fall under the auxiliary aids, including pocket talkers, which is a hearing amplifier. So we would keep these and we would put this in every single department. Radiology, nutrition, ultrasound, ER, all of the inpatient units at all off campus and on campus. So this was like readily available because people will use things, but they do not want to call the supervisor, the nursing supervisor, security to go unlock something, go get them something. They're too busy for that. But if it's right where they have access to it, they will utilize. And this was tremendously successful. And it literally mitigated several of the issues that I had with patient complaints and potential legal action. So just a couple of examples that you can put in there. And last but not least, these cue cards. Next slide, 2 slides. I skipped one, Eric, thank you. The translated cue cards. This is something that you have to keep in mind, that effective communication is essential for all patients, not just those who are LEP or deaf. Patients with disabilities such as speech impairments, aphasia, neurodivergence can also greatly benefit from these tools. Like visual cue cards when appropriate. You providing these resources ensures that equitable access to care enhances understanding, and it's in real time, right? It supports a more patient-centered form of communication. So these cue cards are available in 35 languages, including large print where you can have 4 pictures on one page for people who are low vision. And best of all, they're free. They're through Eastern Health through a grant, and with permission, you can even customize them like I did by adding your own logo, organization's logo to it. Having access to this resource is invaluable, especially with patients of languages of rare diffusion. Sometimes you just can't get what you need in the moment, and at least they can communicate their needs by pointing to the pictures. So this has really helped me mitigate risk on several occasions when no other means of communication was available. So please, the pain scale is vital. And these types of things that are in the toolbox, everything was a one-time use. We didn't want it back from the patient except for the pocket talker because that's a little bit more expensive. That would be cleaned and disinfected per manufacturer instructions. But everything else in that toolbox I bought literally at the general store, the dollar store for $1, or now it's $1.25. Very low cost to provide effective communication to patients. So this is the end of my presentation. Back to you, Matt.
Thanks, Carla. Good job. Thank you. So a couple lightning round questions, if that's okay, for Carla and Drew. So first one of our audience states it's their understanding that it is appropriate to post the non-discrimination notice in English only as long as notice requirements of availability of language services and auxiliary aids accompanies that notice. Is that accurate?
Yes, it is.
Thank you.
And if you post it physically, it just has to be in 20 font.
In 20 font. Okay. Lots of comments, Carla and Drew, about the magnets. Love the magnets, the interpreter identification magnets that you spoke of. Have you ever seen one, or do you have one for auxiliary aids as well?
I do. I created one for auxiliary aids. It's just a little bit bigger. But yes, I do have one. I can share the graphic with you folks, and you can make it available to people.
Sounds good.
That brings me to a question, please, Matt, if you don't mind, because I just had this moment. In my career, and it's been kind of a long one, there's the Joint Commission surveys are different. The DMV surveys are different that come to different hospitals. And in some cases, years and years ago, we used to be able to put signs on patients' door that said low vision, deaf and hard of hearing, blah, blah, blah. Some Joint Commission folks frown upon that, and rightfully so in a way, because I had never thought of it. They feel that it puts the patient at risk. Like if you say that the patient is blind and you put it on their door, other people might be coming into the patient's room to do things, like take things, etc., because the patient is blind. So some of it was frowned upon. I did check out the magnets with Joint Commission and DNV, and they loved them because that was a need to provide care. And it was so subtle, and it was the international symbol with the 3 speaking heads. And I want you to know that the government is actually coming out right now. They participated in a study that they're releasing their own universal symbol for interpreters. So you may be seeing something that you can utilize, but these magnets are extremely reasonable. And they were just maybe this big, they're very tiny, and you just have to remember to take them off once the patient's discharged, right? So that the next English-speaking patient isn't perceived to need language assistance.
2 more. When including the notice of availability on a consent, is it required to have all 15 languages on that document?
Yes. Drew, do you know anything else? I'm under the impression that yes, or not on the document, but with the document.
That's right. I think it is, the distinction is the notices need to be provided with in connection with these identified documents, as opposed to on, because many of you will remember initially there was the regulation required these taglines. They're no longer called taglines on substantial communications, and everyone was wondering what is a substantial communication. Now in the regulation, it's specifically identified, as Carla has alluded to. So the notices need to be provided in connection with that document, not necessarily on it.
And that brings me to one other really sticky thing, uninformed consents, consent for surgery, for instance. There's a witness signature. Now, Drew, I've checked with lots of legal people on this. Unfortunately, I've had to have clear communication in this sense. And I was told that interpreters should not be signing as a witness anything except for a healthcare proxy, which anyone can sign as a witness, okay? That interpreters, because they're partaking in rendering the message in the consent, that they should not be the witness, it should be somebody else. However, my best practice was that I had an interpreter signature spot on the consent, or if it was done by VRI or OPI, that it would have an area where they could put the ID number of the interpreter. And the reason that I did that, for those of you that have gone through Joint Commission or DNV, if a Joint Commission surveyor is reviewing the chart and they see a consent in English signed by a patient who's clearly LEP, they're going to ask, how did you do that? And if the provider did not document, and a lot of them are not very great at documenting utilization of interpreter services, and if you don't have an integrated EMR with your LSP, it becomes very difficult. At least the documentation was there. And oftentimes they would stop reviewing the chart right there because they said, oh, look, they utilized this interpreter. It's right here. If it's not documented that clearly, they will keep digging and digging and digging, and they'll probably find 5 other areas like blood transfusion, et cetera, or patient education where you did not utilize an interpreter.
Last one, and then Eric, I'll move to close after this. So for Carla and Drew, earlier in the session, you spoke about NCIHC, and the request is, are there other organizations like that you find that we should be monitoring on a regular basis?
There's a lot of organizations. I have to tell you, what I find myself doing is I love to listen to a lot of podcasts, a lot of webinars. I'm constantly on the search of things. Even to prepare for this, I went on YouTube, believe it or not, and I found some great resources of other people who had done presentations on Section 1557. NCIHC is the national one, not because I'm the vice president, but I honestly would not be involved in it if I didn't find value. There are interpreter organizations, but if you're not an interpreter, they don't speak as much to compliance, risk, regulatory types of things. And then Safe AI, I can create a list that maybe Eric can share with the participants, because it's too many for me to think of right now. And maybe Drew, if you have any that you want to share, we could combine the list.
I would recommend looking into the American Health Law Association's federal non-discrimination publication. A second edition just came out, which will likely need a third edition, in a few years after the regulation is modified and there are more developments. But that is a good comprehensive resource from a legal perspective on what we've talked about here today.
Thank you, guys. All right, so we're going to move to wrap. So again, my thanks to Carla and Drew for their wisdom and insight today and to the great questions that came in. We will continue to work through the questions and reach out to folks with that information afterwards. As mentioned, the recording of the session and all of these resources, plus some of the others that were mentioned ad hoc today, will be included and sent to all participants. And on the next slide, just to get into sort of 3 next steps, again, you'll get the slide deck and the resources. A reminder, our next session is January 15th. And if you've got questions, please reach out to your AMN Language Services Client Manager or contact Moira Kelly, who's on the slide below. My thanks again to the ASL and CDI teams from AMN who are on the call with us today. Thank you so much. Thank you again, Drew and Carla. Happy holidays, everyone, and we will talk with you all in January. Have a great day.
Thank you so much, Matt. Thanks, Drew.
Thank you, Matt. Yep. Thanks, Carla.
Thank you, everyone.
Bye, everyone.
Bye-bye.